As a menopause, guys, I have all things menopause on my radar, and that does include our bones because that's very definitely a part of how we move through life all the way to the end. And when our bones become brittle, we lose independence. And when we lose independence, we become frail, and life goes down the tubes fairly quickly. I hate to say that, but it is true. And I am a bit alarmed at how many women do come into my clinic already with osteoporosis because they're not tested until later on in life. And women do come in with osteopenia as well. But there's a lot that we can do to stop this bone loss and early on, and also to build bone back up. So this is a pretty big topic. And because it is a big topic, I have made a presentation so that it's just a little bit easier to follow along. So here we are, how to keep our bones. So what you'll learn during this presentation, so a little formal here, is why it matters and that bones are actually living things. And there are specific risk factors leading to bone loss that I think a lot of women, people in general, don't understand. And when to test, what it actually does tell you, the types of tests that you want, what you can do to prevent and reverse osteoporosis, natural nutrient or nutrient status and supplementation is important to look at, lifestyle factors, which includes movement, diet, and stress. And then medications for bone loss prevention, we want to look into those, the pros and cons. And then a lesser known or talked about therapy to prevent bone loss is hormone replacement therapy. And yes, I am going to be talking about that because it's important to know the risks, the benefits, and where it falls in relationship to keeping bones. So that's a lot, right? Before we move forward, I do want to stress that bones are not static. We kind of think that maybe bones are static because, when we look at a skeleton, it looks pretty inert. But the bones in our bodies are building up and breaking down constantly. And we actually turn over our bones about every 7 years or so. And we have two types of cells in our bones that are really important to know about. The first one is called osteoclasts, and they are the cells that are responsible for breaking our bones down. And we do need to have a breakdown of bones in order for our bones to build up, and we build up our bones through the use of osteoclasts. So osteoclasts and osteoblasts are very dynamic, and again, it keeps our bones strong and viable and giving it mobility as well. So keep those two words in mind because I'll be referring back to those again as we move forward. Here are some sobering facts. 30% of women over the age of 65 who come up with a broken hip, which is actually the top of the femur bone, is really what is breaking there. It's not the actual pelvis area. 30% will die within the first year. And 50% will not be able to come home from a care facility. And the 30% who will die, it's not from the operation or the surgery itself, because usually that's pretty easy to do. It's what happens afterwards and what happens in the recovery. So in most cases, women will need to go to a care facility to rehabilitate, right? And often there isn't somebody at home that can actually help with that. And so a person goes there and they're going to be more prone to catching a bacterial, a viral infection, number one. Number two, they will be less mobile. Everything will be taken care of for them. If you think about all the little movements that we make throughout the day, like walking to the restroom or making our own meals, picking up something, moving on and off the bed, just as daily movements, which may not seem like a whole lot, is cut back even more in a care facility. A woman is going to be more prone to UTIs, partially maybe because of wearing a diaper or not going to the bathroom as often, and just more moisture there. And often what happens, you're going to be losing more muscle mass, and muscle mass is what's going to help our bones to build. It's going to help our bones move. So there's just a frailty that comes once we have the surgery and that type of surgery and then the care. And so again, it's not really the surgery that causes the death. It's the increased frailty, increased UTIs, and susceptibilities to infection. And, depression after this can also be a part of it. So, some more stats. Women lose 20 to 40% of their bones during the first 8 years of menopause. That's a lot. I would say average is probably 20 to 25%, but it can be as much as 40 depending on her already risk factors that are in place. Yet, most women do not receive their first DEXA scan until age 65. So, if the average year or the average age of women going into menopause is about 50, they're not getting their first DEXA scan until 15 years after that, until 15 years after they've lost their estrogen, which plays a huge role in this. And again, I've already said 25 to 30% of people over the age of 65 will die within the first year of breaking a hip. So growth and loss, our bone building years are ages 12 to 25. So if we are not putting on the bone that we should be for a variety of reasons during that time period, we can come into menopause in a bone deficit or bone density deficit and quality as well. So what are some of those factors that can contribute? Well, weight. If we tend to have low weight as we're growing up, so maybe even a little bit of an eating disorder, or you're an elite athlete, that can be an issue. And if we're underweight and possibly an elite athlete, we are not menstruating. And so the amount of estrogen that normally a young woman would be making, and again, estrogen has a huge role in keeping our bones, she may not be laying down the bone that she requires during ages 12 to 25 years of laying down bone. Genetics can play a role as well. Stress can. Cortisol will leach minerals out of our bones. It's amazing how that does that. Our nutrient status, there's a variety of reasons why we may have low nutrient status. And when I talk about that, I'm not talking so much about calcium, but I'm talking more about magnesium and vitamin D, which so many people are deficient in, and even vitamin K, which helps vitamin D escort calcium and other minerals into the bones. So let's say menopause happens, before the age of 45. I would say that would be early onset. And that can happen again from a variety of things. It can sometimes stress, if it's extreme stress, can put a woman into early menopause. More commonly, the cause for early menopause is either surgically or chemically due to cancer. So either her ovaries are removed or she has had an aromatase inhibitor or something to really pull her estrogen and hormone levels down as treatment for cancer. But other medications that some people, don't even think about that is a real problem. There's three others that I can come up with. One are PPIs. So PPIs are proton inhibitors, and they're used specifically for people who have acid reflux and GERD. And the problem with that is we require adequate amounts of stomach acid in order to break down and cleave the minerals that are coming from our food. So if we are inhibiting that, then what's available to us from what we're eating is also inhibited. So that's one thing. Another thing that can inhibit our ability to absorb nutrients is an inflamed digestive system. So let's say something like celiac disease, which is actually an autoimmune disease. The celiac disease, I think most people know what it is. And our body responds to gluten in a very inflammatory way. And that itself causes so much inflammation that the body cannot absorb the nutrients that it needs. So That was more going back to the nutrient status. But other medications that people don't think about would be steroids like prednisone. And often we'll use that for, let's say, asthma. We'll use that for a lot of inflammation and pain. So people who have used an steroid inhaler for years on end have a higher risk for osteoporosis than someone who doesn't. So you really have to watch that and test at an earlier age. Another medication would be SSRIs. It can also deplete the body of the nutrients that it needs. So we have diet, right? Can be a risk factor. So we need adequate amounts of protein to build muscle because muscle is what puts the load on the bones and moves the bones to strengthen them. So if we have someone who's been a vegan for a long time, that can increase the risk of not having strong bones. And I already mentioned how adequate protein affects muscle mass. So that's important. We have to have adequate amounts of muscle mass to bring that load. And then fragility, which again goes with muscle mass and how much we move. I didn't mention genetics yet, but there is a genetic component to osteoporosis, and Caucasian women and Asian women are more prone to bone loss and osteoporosis than other ethnicities. So my little skinny, small boned, and anxious women are the ones that are more prone. All right, testing. There's a couple different types of testing that are important, and I want you to understand what these are. So I would say probably the gold standard. I'm not necessarily saying this is the best, but I would say that the gold standard is the DEXA scan. It's looking at the bone density of your spine and usually one of the femur bones or your hip. And that gives you a T-score, and the T-score will tell you there's ranges of where you fall, okay? And the T-score is basing what your bone density is on, let's say, a 25-year-old. So that's what they're comparing it to. And if you go into the negative or have a negative score compared to, let's say, a 25-year-old, then you're moving into either osteopenia or osteoporosis. Anything less than -1, in other words, I mean, you have a -1 and higher, okay, so you don't have any negatives, then you're good to go. When we move into osteopenia, it's a -1 to about a -2.5. And then osteoporosis would be a -2.6 on up. So it's looking at bone density. It's not looking at bone quality. And that's two different things. And most doctors do not really look at your bone quality, but just are focused on your bone density. So it is limited to a certain degree. Do I think it's necessary? Yes, but it does have its limitations. And then I'm going to skip to the REMS and the Echolite, and that's more of an in-office type of ultrasound, and that looks at both bone density and bone quality. I'm not as familiar with this, but I think more and more doctors who are working with women are having these in their offices. Now, DEXA scans historically, again, I said it's covered by Medicare, but a lot of women don't get their DEXA scan until they're 65, and often they have to ask for it, which is absolutely ridiculous. And, if you know all of these risk factors that I just mentioned, and you have a couple of them, there's absolutely no reason why you can't ask for a DEXA scan at a much earlier age. And if there is osteoporosis in your family, that's also a big risk factor. I didn't mention that before. And then there are blood markers, and these two right here, the CTX and the P1NP. And I recommend every woman have these done. Whether or not they have osteopenia or osteoporosis, it's really nice to get a baseline. It's really nice to get a baseline as well with a DEXA scan. When a woman's in perimenopause, when she usually doesn't have a whole lot of bone loss yet, so it's nice to have that baseline. It's nice to have a baseline of these, again, two blood markers, the CTX and P1NP, so you know where you're moving from, right? So let's talk about these. The CTX is just a simple blood marker of how much your body is breaking down bone. So it's measuring the osteoclast. Remember I talked about that? And it breaks down bone, shows that. And then the P1NP shows us how much osteoblasts you have to help build up the bones. So you want to have both of these done and look at the ratio of one to the other. Make sure one's not doing more than the other one is. I have found that it's pretty easy to get the CTX. It takes a little bit more asking around to get the P1NP. The labs that I use, they do offer the CTX, but they do not offer the P1NP. So I do offer blood tests, and that is one of the things that I do offer. All right. So I kind of already talked about the risk factors. I'm going to talk about it again, going into it just a little bit more. So this is your nutritional status, right? So we want to have adequate amounts of vitamin D. And I have so many of my clients come in with low vitamin D status. And it's simple to test and it's simple to remedy for the most part. And you do want to have the vitamin K because it helps the vitamin D escort the calcium into your bones. And I know there's a lot of focus on calcium and adequate amounts, and we do need adequate amounts, but that's only like maybe 13 to 1500 milligrams a day. And we want to get the majority of our calcium from our food, which includes our dark leafy greens as well as animal sources. Okay, magnesium is huge, and it's really not talked about so much in mainstream medicine. But magnesium is definitely part of that bone matrix, and we have to have adequate amounts of magnesium. And it's best to test using RBC specifically blood. So not just straight serum, not just straight magnesium, but specifically RBC. You have to mark it that way. And then there's something called tocotrienols, which is a type of vitamin E. And vitamin E kind of fell out of vogue, I guess, about 20, maybe 30 years ago. It was, touted as a really good antioxidant. And it is. It still is. It's just that they were looking at the wrong type of vitamin E. So specifically tocotrienols are really helpful with maintaining bone as well. And I already mentioned how digestive issues and status can interfere with the absorption of all of this. And then I already talked about the risk factors, but Caucasian, Asian, small bone, thin, anxious, and increased cortisol, and being a competitive athlete, diet and muscle mass. I guess I got ahead of myself a couple slides back, but here we are. It always is good to go through a review, right? So we have nutrition, having adequate protein, right? Having adequate greens, having adequate sources of calcium and magnesium. That's all super important. And then movement is very important. A variety of movement as well, okay? Not just building up muscle, but moving our bodies and also practicing our balance. That's super important. Those little twitch muscles, really important for stability and working the muscles and working the bone. We want to put some torque on our bones and some twisting on our bones. Weight bearing exercise, yes, it's important. Balance, I just talked about that. And then moving away from fragility to more strength. Okay, medications, PPIs, steroids, antidepressants, I already talked about that. And then I did mention risk factors would be going into menopause. All women are going to be more at risk the first 8 years or so of moving into menopause is where we'll lose about 20% of her bone mass. And that is due to the loss of estrogen and progesterone and testosterone, but mainly estrogen. And again, I mentioned that there can be a loss of hormones and going into early menopause if we have surgical or medical interventions due to cancer. Usually that's what it's due to. It can be due to other things as well. Okay, so monitoring and testing, I already talked about the DEXA scan. One of the issues with, mainstream medicine, again, is if a woman goes in and she has a DEXA scan and she's maybe moving into osteopenia or maybe more dangerously into osteoporosis, they'll give you a prescript or they'll give you medications and they say, we'll see you in 2 years. That's way, way, way too long. So again, there's other things that you can be doing, and that would be monitoring your osteoclast and osteoblast with these two serum numbers. Again, that's a blood test that gives you feedback. And if your doctor has Echolite or REMS, it would also give you the density and quality, and you can test that more often. You can request a DEXA scan more often as well, and I would with your doctor. And if your insurance won't cover it, you can always pay it out of pocket, and it's not that expensive. It's maybe $100 out of pocket, and I think it's well worth it. Supplements. So here are some of the key supplements that can make a difference. The quality and the form of these supplements will make a difference. Again, we want to get most of our calcium from food sources, natural sources. But if we do need to also supplement, we want maybe 300 to 500 milligrams of calcium citrate or calcium hydroxyapatite. And doctors who prescribe more than 500 milligrams, I really question their knowledge of how the body really works when it comes to calcium. We don't want to overdo it, and we don't want to have a bunch of calcium around in our circulation to possibly become deposited in areas where we don't want it to be deposited, other than the bones or soft tissue. Again, we want to have our vitamin D. And depending on where your levels are, I like to see vitamin D levels, serum vitamin D levels at around 50 to 80. I know that the range goes all the way down to, I think, 32, which is way too low. Vitamin K, about 20 to 50 micrograms. Magnesium glycinate. Glycinate is the form that I like to see. There's oxide and citrate, which you often see in cheaper types of magnesium, and they are not as readily absorbed. And then vitamin C is really important because that's part of absorption of our minerals and also building collagen, which is very important. Collagen is part of our bone matrix as well. And yes, collagen is good to add. And there are different types of collagen that have been tested specifically for increasing that matrix, and either collagen with the name of Forte or Forte Bone is what I would recommend, in 20 to 50 grams a day. And then again, our tocotrienols, which I mentioned before, you want about 300 to 500 milligrams per day. And I do have an online dispensary that carries all of these, and I will include a link in the introduction or in the notes that links specifically to a protocol that I put together for supplementation to keep our bones. Movement. So what's the best kind to stimulate bone? So walking is really good. Should you wear a vest? Well, it depends. It depends on how your spine is, how strong it is. It takes a certain posture to carry that vest and a certain strength to carry that vest. And if someone has lost a lot of bone in their spine, that's probably not something that you want to do. It puts added pressure, compression on the spine. So it depends on whether or not wearing a vest is good or bad. Dancing is wonderful. Dancing uses big muscle groups, and again, that helps with our balance. Resistance training, whether or not it's with weights or with bands, is also good. But here again, we have to look at the person in front of us and how frail, how strong that person is, what the bone structure is like, density is like. And we don't want to add a whole lot of heavy weights to put that load on. I would say probably starting with bands and building up the muscle and building up the density that way is a better way to start. Steps and stairs are also very good. Even just a little step going up and down, not necessarily doing a flight of steps, but just stepping up 1 or 2 inches, stepping down 1 or 2 inches. Vibration plates are really good. Again, that kind of puts torque on our muscles and our bone, and it makes our bones and our muscles react in very, very small movements. Yoga and Tai Chi are wonderful, again, for balance and for flexibility. Flexibility is really, really important. And then there's a program called OsteoStrong, which is a series of movements that are put together specifically to build bone. And There are a lot of programs online. There are some programs or some studios that offer OsteoStrong nationwide. There's just not that many studios, but you can go online and look at that. Medications. So there's a couple different classes of medication. So what we have here, we have anti-resorptive drugs, which works on the osteoclast. And that's basically, the biphosphonates that we'll find in the form of Fosamax or Reclast or Prolia. And the Prolia is an injection about every 6 months. The Fosamax and the Reclast are daily medication. And the downside of these is it stops the action of the osteoclast, so the breakdown of the bone, right? And so we're just kind of keeping our old bone there. It's not dynamic. And so we can't have the buildup of good bone coming in. So that's one thing. You can't be on these medications, the biphosphonates, for longer than 5 years because they can cause a fracture in the top of the femur bone, all right, which is basically what we want to stop. And it can also cause what we call necrosis of the jaw or loss of bone in the jaw. And so it can compromise too dental work. You have to be really, really careful about dental work when you're on these biphosphonates. What else do I want to say about that? They can also be really hard on the digestive system. And so if we have somebody that has digestive issues, it can possibly make this worse. Then we have the types of medications that are actually bone building. We call these anabolic, and these work on the osteoblasts. And the osteoblasts, again, build up the bone. And the two that I'm familiar with is the Forteo and the Tymlos. There might be one or two else out there. And you can really only be on these for 1, maybe 2 years max. And then you do need to come off these as well. And you probably need, as you're coming off of these, to make sure that you are taking a little bit of the biphosphonate as you're coming off of these. So there's a real balance here with these medications. There's pros and cons with these medications as well. And I would encourage women to do everything that they can nutritionally, movement wise, in order to organically, I guess that was what I want to say, build up their bone mass because they can. Okay. There's something else I want to talk about in the next slide, in addition to these particular medications. So again, these medications, I think they would not be my first line, right, of treatment. There's so many other lifestyle and dietary things that you can be doing, but they are appropriate if a woman is increasing her osteoporosis, her numbers are getting more and more negative. It might be necessary as a stopgap as she works on other things to build up her bones. So it's not the first line at all, in my opinion, in my book. There are significant risks, but sometimes it is appropriate. Hormone replacement therapy, I guess, could be considered a medication as well because we can't get it unless it is prescription, and it is very therapeutic. And I'm talking about estrogen, progesterone, testosterone. And estrogen was actually approved by the FDA back in the 80s as a therapy for prevention of osteoporosis. In fact, it was the only drug therapy that was approved to prevent osteoporosis before the biphosphonates came out. Okay. And so that was back in the 80s, and they did use it. And it wasn't until the Women's Health Initiative, that study that changed the whole idea of HRT, unfortunately, and the outcome of that in 2003, it wasn't until then that all of a sudden the recommendation for using HRT just went out the window. It is the most effective therapy to prevent bone loss without the many, many risks, for most women anyway, that the biphosphonates have or the anabolic medications have. So it's more effective than the biphosphonates. And it's interesting how the women that come into my clinic, maybe 1% have even been offered estrogen as a means for preventing further bone loss. And that's a tragedy. And the other tragedy is a lot of women, again, aren't diagnosed or know that they have osteopenia or osteoporosis until age 65. And there's still this stigma that women who are outside this 10-year window of going into menopause are no longer eligible, or no longer is it safe for them to be put on hormone therapy treatment. Now, that dogma is slowly changing, but definitely not fast enough. So even if a woman might want to go on HRT, her doctor may refuse her. There are doctors out there who are trained in HRT who know differently and better, but it's a very small percentage of the doctors that women actually see. So hormone replacement therapy is very effective. The estrogen prevents the breakdown, so the osteoclast slows that down. And then even progesterone and testosterone can be very effective. Progesterone can help with the osteoblasts, the buildup, and testosterone even more so with the buildup of the bone for a variety of reasons. One would be that it helps to build bone mass, muscle mass, right? And the more muscle mass that we do have, the more the bones are supported and can move better. So is it possible to reverse bone loss? Yes, you betcha. And that's something that we talk about in my course, Grace in Transition for Women of a Certain Age. And you can find out more about this course by going to alivingbalance.net and going to course. You will find out what the Grace in Transition course is all about. So again, this is one of the many things we talk about. There are other programs out there and people to listen to. I think Dr. Doug Lucas, you'll find him on YouTube. He may have a podcast by now, but he has a program which is very good. And I think that his YouTube channel gives wonderful information. And I would recommend that anyone's concerned about it to go to his channel there. So that pretty much is a quick run through of osteoporosis, what your risks are, how you can prevent it, how you can build bone back, and the risk factors that come with losing bones that I think most women don't worry about. I think they worry more about cancer, but losing bones is a big issue as well. So I hope that was helpful. Again, in the show notes, I will have a link to the course. I will have a link to my online dispensary specifically for supplements that will help to keep your bones. And then if you like this video, please like and subscribe, and I'll be putting more up here. And if you subscribe, you won't miss anything that I do put up. So thank you so much.